Stanford University.
Thank you, Holly. Well, I'm honored and glad to be here, and it's probably relieving some of my anxiety that I can't find out what the election reports are for an hour and a half or so. But living with uncertainty is something that cancer patients live with all the time, and their families, and we're all living with at the moment. So hopefully we'll all have a good outcome. I'm pleased to be here on behalf of the survivorship program at Stanford, and Holly has been doing some wonderful work in running that program. It's great to have a place where people can live with cancer. You know, it used to be cancer was considered a terminal illness, and people didn't want to mention the C word or the D word. And can you hear, by the way? Is that right? Speak up a little? Okay, I will speak up a little. I hope you enjoyed my lecture. It used to be considered a terminal illness. Now we're thinking of it more as a chronic illness, you know, something more like diabetes. Half of all people diagnosed with cancer will live to die of something else, which is a good thing. But it means that there's more and more importance to the notion of survivorship and in helping people live as well as they can, as long as they can with cancer, and there's a lot of stress involved with that. So what I hope to do is share with you some of what we've learned over 3.5 decades here at Stanford, trying to help people with cancer live better with the disease and learning from them. And I'm very grateful to them. They've given generously of their time and their experience to help us understand better how to be of help with cancer. So I want to dedicate this lecture to the memory of Ernie and Izzy Rosenbaum. Ernie was an irrepressible, wonderful man who started supportive care for cancer patients like 30 years ago at Mount Zion Hospital before anybody even thought about doing it. And he worked tirelessly. He brought, as Holly mentioned, the program here to Stanford just out of the goodness of his heart. You know, normally people call you up and they say, oh, I've got something for you, you know, it's going to be wonderful, and then you pay the piper later on. It was never the case with Ernie. He was just giving and giving and giving, and he brought the program down here. And the reason it's here is because he did that. Whenever you'd call him up on the phone, he'd say, just the good news, David, just the good news, that's all I want to hear. But he was really good at dealing with bad news and helping his patients deal with bad news. And he was with them anytime, anywhere. He was also the doctor to the opera, and Pavarotti used to call him my friend Ernesto. And he was a real fixture in San Francisco in the art scene as well as medicine, and just gave throughout his life. And he was a wonderful, supportive guy, and I miss him and the love of his life, Izzy, who kept him on track for some 45 years or something like that. They were deeply in love with one another, and it was a real pleasure to be with both of them. And he carried on for several years after Izzy's death. I was frankly worried about him, but he was so busy giving to people that it really helped him with his own grief about Izzy's death. And so he's just a terrific guy. So this lecture is dedicated to him. These are some of the books that he wrote. He wrote a number of them: Cancer Supportive Care, Cancer Survivorship, You're Not Alone. And they're still wonderful reading, and we're actually in the process of putting together a website that will provide access to these and many other books as well, and we're working on a final book that he was writing. I just ran into one of the colleagues who said, you know, I had a wonderful but strange experience. He said, 2 days after Ernie died, I got a letter in the mail asking me to update the chapter I had written for his book. So, you know, right until the day he died, Ernie was working on it, and we will get that done too. So what I hope to review with you is issues of stress and depression related to cancer, some psychotherapeutic treatments that we have to help people deal with cancer, what the results are, and examining the rather interesting question of whether helping people excuse me, to live better may also help them to live longer, and what we think some of the pathways are. And I hope to leave you with some points about how one can deal more effectively with the inevitable stressors of cancer. We were running a support group one day, and in marched one of my metastatic breast cancer patients with this life-size dressmaker's maquette that she had redone to show the effects of cancer on her body. And so she had had a modified radical mastectomy with a tram flap reconstruction. She had radiation burn. She had an open biopsy there. Now, I'm glad to say that since the time that she did this, the treatments have become less invasive and less damaging, but it still happens. And this was her way of reminding us that you live with these things all of your life. You can't forget them. Every day you confront the effects of the cancer and its treatment. And so it's not just one big stress, it's a series of stressors that people inhabit in their own bodies. And part of the stress of dealing with cancer is in a way reconstituting your relationship to your own body. Because unlike other illnesses where, you know, your heart or your kidneys or your liver let you down, cancer is different in that the part of your body becomes the enemy. And so you have to kind of come to terms with the fact that one part of your body is doing damage to the rest. And that's a difficult thing to live with. She gave me permission to use her name, so this is not a HIPAA violation. Her name was Maurice Jaffe. She was a Silicon Valley engineer when she started doing this, and by the time she died, when she got metastatic disease, she said to me, you know, I've always wanted to be an artist. I've been a good engineer, I'm tired of it, I want to be an artist. So she went back to school, studied, and was teaching art, and had produced a very beautiful body of art by the time she died. So she had used cancer as an occasion to change her priorities in life, which is one very good way to handle the stress of cancer. As I had mentioned, the number of cancer survivors is growing. This is a good problem to have. Medical care is getting better. People are living longer with cancer. So in the 1970s, there were 3 million cancer survivors in the United States. Right now, there are more than 12 million. So the number is quadrupled. That's a very good thing, and some of you are right here in the room. And so people are living better and longer with cancer. And that means that the issue of survivorship and helping people deal with the stress of cancer is a growing and important issue for us to deal with. The Institute of Medicine of the National Academies has issued a report called Cancer Care for the Whole Patient. And what they noted is that addressing psychosocial needs should be an integral part of quality cancer care, and that evidence supports the effectiveness of services aimed at relieving the emotional distress that accompanies many chronic illnesses, relieving it, not reliving it, including cancer, even in the case of debilitating depression and anxiety. So there are good treatments for the emotional problems that go along with the physical problems, and we need to think of them as coexisting issues that we can deal with effectively. This was done by a French cancer patient I knew who depicted cancer, which is, you know, the word cancer was the Greek for crab. Crab-like growth was the idea. And so she lost her hair in chemotherapy, and she decided that she would image that by replacing it with the crab. And I'll show you some more of her drawings. But she had a sense of humor. And you know, it's a wonderful thing. You know, laughter can be a great thing, even in very difficult situations. One of our support groups, one of the women said, you know, my husband is hopeless at organizing anything, and so I'm going to have to organize my own burial, actually. So she called Skylawn Park, and she asked what it would cost for her to be buried there. And they quoted her an astronomical amount of money. We all know what real estate costs in Northern California. And she said, well, you know, actually I represent a group of women who are looking for a place to be buried. And there was a very long pause, and the woman at Skylawn Park says, Skylawn Park does not offer group discounts. And the wonderful thing is that all of these women with metastatic breast cancer got a good laugh out of trying to get a group discount at a cemetery. So you can face anything if you do it together and sometimes with humor, and that's one of the lessons that we learn here. So there are many stressors in dealing with cancer. There's the existential issues, and everybody thinks cancer is going to kill them, even though in at least half the cases it won't. There are problems related to pain, the meaning of the diagnosis, fear about recurrence, very important treatment decisions early on in treatment, changes in social environment. I tell the students, you know what, if you had to live the life of a cancer patient for a month without having cancer, you wouldn't be feeling so good by the end of it, because instead of doing the things that you like to do or that make you feel productive, you spend your time sitting around waiting rooms reading stale magazines, surrounded by mostly strangers, people who don't know you and don't know who you are. And that in and of itself can get demoralizing and depressing. on top of also feeling sick and having side effects of chemotherapy and other things. So the social changes related to cancer can be powerful. The treatments are very hard to go through. And people often find themselves feeling depressed, sad, fatigued for months after their chemotherapy or their radiotherapy is over. And they often blame themselves for it. They think, you know, if I were really tough, I'd be out there, you know, jogging the next day. Actually, exercise is a good thing to do, even during chemotherapy. And one of my tips about living with cancer is do what your grandmother told you to do. Eat well, sleep well, and get plenty of exercise. And that is especially true during cancer, because you need to think of your body as being in training to cope with the disease and with the treatments related to the disease. We tend to think, you know, I can forget about cholesterol and all those other things because I've got cancer, that's what's going to get me. Well, you know what? More women die of heart disease who have breast cancer than die of breast cancer. So it's very important to take care of your total health and think of your body as being in training and treat it the way you would if you were in training for anything else. This is my French patient who said the villain crab goes on the attack here. And so this is her sense of a part of her body being the enemy. So my summary of, and I will go through this in some detail, of how I think it's best to face cancer is summarized by the acronym FACES. Whoops, whoops. Wrong way. Here we go. The acronym FACES. So the first thing is face it rather than flee it. Many people would rather avoid or pretend they don't have a problem when they do, and that just makes the problem worse because it pursues you. If you face it head on, you can figure what to do about it. And the second, it is very important to cope actively with the disease. Feeling helpless is something that only adds to stress. Life always has stress in it. If we weren't stressed, we'd be dead. It's just a part of life. But if you don't feel you can formulate a plan for how to deal with the stress, you feel more helpless and more stressed. So the idea here is face the problem. Excuse me. Learn. Sorry. Hey, Holly, would you mind getting me some water, please? Thank you. Learn to alter your perception of what the situation is. See it from a new point of view. And I'll show you some techniques that we use to help people do that, to alter their perception of the situation, cope actively with it. Find some aspect of the problem you can do something about. Express rather than suppress emotion. Emotion is your friend, not your enemy. Many cancer patients and their families feel that if they somehow suppress how they feel about cancer, that they can actually control the disease, and it doesn't work that way. Emotion is our signal system telling us that something is important, we better pay attention to it. And using those emotions to help face and deal with what you're dealing with, help build social support, can be a very helpful way of coping with the disease. And the final letter is social support. It is, yeah, I'm sorry, Holly will get some more. Social support is an absolutely critical aspect of coping with any kind of stress. We are social creatures. We're not just splendid individuals. And for human beings, social support is a survival mechanism from the time that we were running around in caves. And so it is tremendously important to gather social support and use it. What's it? Oh, thank you. Aren't you nice? Thank you. Medication here. This is really good. All right. Thank you. This is my French patient's depiction of how the treatments are long and hard to undergo. And one of the paradoxes, you know, I tell my medical students that it's much harder to be an oncologist than a cardiologist. And anybody know why? Any thoughts about why that might be? Well, you know, if you are brought into the emergency room with crushing substernal chest pain, you think you're going to die. Your cardiologist is with you for a couple of minutes, and suddenly you think you're going to live and the pain goes away. So you instantly love your cardiologist, right? But what's the deal with oncology? It's exactly the opposite. You think you're fine. You got a lump or a little bleeding or something, and the doctor's words transform that into a life threat. And then the treatments feel much worse than the disease. You know, Susan Love calls it slash, poison, and burn. And so very often, oncologists have to work around the natural feeling patients have, thank you, Holly, that they're being punished, by their doctors. So it's one of the ironies that cancer treatment is such an ordeal. She also noted that there's a great sadness that often comes with the disease. And sadness is a natural part of human life. It comes along with having cancer at times. But it can sometimes morph into something worse, depression. And the difference is you feel sad about something that would plausibly make you sad. Depression is feeling hopeless, helpless, and worthless. It's feeling that there's nothing good is ever going to come, that there's nothing you can do about it, and that there must be something wrong with you that got you into this situation. And so when it extends beyond just what it is you're feeling sad about to those senses of hopelessness, helplessness, and worthlessness, that's when you're getting depressed. And depressed people are fatigued, they don't sleep well, they don't eat well, they don't do things that will help them cooperate with their treatment. And depression is not a natural concomitant of cancer. It's a comorbid illness. It's another disease that we know how to treat, and it requires attention and treatment. About 3% of the general population are depressed, and I suspect the numbers will shift, and it'll be higher than 3% in either red or blue states and lower than 3% in others later on this evening. But the overall average is about 3%, and at the moment I'd say they're all anxious rather than depressed, but we'll see what happens. Among medical outpatients, the rate is twice as high, it's 6%. Among medical inpatients... I'm sorry?
Could you briefly define what...
Yeah. Depression is a feeling of pervasive sadness that involves hopelessness, helplessness, and worthlessness. So you, in general, feel not just that a bad thing that has happened or that you've something you should feel sad about, but there's something wrong with you. You don't deserve anything better. You have fatigue, you don't sleep well, particularly waking up early in the morning, and you have this pervasive sense of misery and sadness throughout your life. It isn't just sometime, but all the time, for a protracted period of time. You feel sad. These numbers are U.S., but they're not so different from the rest of the world. But this is U.S. prevalence, yeah. 6% among outpatients, 12% among medical inpatients. 1 out of 9 medical inpatients are clinically depressed. And unfortunately, it's often overlooked. With cancer, for example, people say, well, of course she's sad, she's got a bad prognosis. Of course she isn't eating, she's got nausea from chemotherapy. Of course she isn't sleeping, she's worried about the disease. But in fact, that may not be the situation. The situation may be that they're depressed. About a quarter of all cancer patients have clinically significant depression. About 20% of the terminally ill. And interestingly, there's a vote, I think, in Massachusetts about assisted suicide, which I am not in favor of. 2/3 of people who request assisted suicide are depressed. And depressed people get suicidal. And it's a psychiatric problem, it's not a medical problem in that sense. It should be treated. I think that any doctor who seriously considers deliberately killing a patient ought to sit down, take a deep breath, reread the Hippocratic Oath, and help the patient with their depression, their pain, and other problems relating to the disease. Most patients who request assisted suicide, if you don't do it, and wait a couple of weeks, will change their mind. But you can't change your mind if you've already done it. So depression is an unrecognized and very serious problem. It's a serious problem in another way. Our group published this in the Journal of Clinical Oncology last year. And what this is showing, and I'll show you a number of slides like this, these are called survival curves. And basically what they show you is the odds of being alive at a given point after the time you initiated the study. So everybody was alive up here, and the more sharply the curve drops, the more rapidly members of that particular group die. And what you see here is the yellow line are people whose depression in this baseline period was getting worse, and the blue line are people whose depression was getting better. And the ones whose depression was getting better, as you see, lived significantly longer than the ones whose depression was getting worse. And we, in this analysis, controlled for all the usual risk factors for breast cancer: estrogen receptor status, progesterone receptor status, HER2/neu receptor status, age at diagnosis, time from initial diagnosis to relapse. And independent of all those risk factors, being depressed predicted shorter survival. So treating depression, in theory, could help you live longer as well as better. Yes?
So have you been able, are you beginning to look at what the physiological interaction is between depression and the disease?
We are, and stay tuned. A little bit later in the talk, that's exactly where I'm heading. Thank you. So the average difference between those whose depression was getting better and those who was getting worse was about 2 years, actually. So it's not a trivial amount of time. So it suggests that we really ought to be thinking about treating depression and stress in addition to all the other things we need to be doing to treat cancer. So how do we do that? How do we treat it? This, by the way, was done by a Dutch breast cancer patient to depict her own despair about the disease. And one thing that continues to astound me is it's the only work of art she did in her life, was that sculpture, which is really a remarkable sculpture. So there are medications that are helpful for cancer. Many of them work on the serotonin pathway, which is a major neurotransmitter that is related to mood and impulse control in the brain. Norepinephrine is another major transmitter, and some of the antidepressants work on that as well. There is now some interesting research on brain stimulation, what's called transcranial magnetic stimulation, that may stimulate certain parts of the brain. And as I was saying, there are these various somatic ways of treating depression, and there are also psychotherapeutic ways that are very effective. Some people respond to one or the other, some respond to both. But we have an array of effective treatments that should be used in treating depression. Yeah.
In terms of, you're on these strong medications, have they studied the interaction of the mental illness medications and the cancer drugs?
Well, some of the, in this study that I showed you here, some of these people were on medication, and so the course of the depression was related to the medications, in part to psychotherapy, in part some people just naturally getting better or worse. It's important, one thing that is worth keeping in mind if you have breast cancer and are on these medications is some antidepressants actually compete for the metabolism of tamoxifen. So if you're on tamoxifen as an estrogen response modulator for breast cancer, some antidepressants may be a problem. Some of them are not, but it's very important to talk to your doctors if you're on it, because they can make the tamoxifen less effective, because the active form of tamoxifen is a drug called endoxifen. It has to be metabolized by the body, and some antidepressants will impair that. So it's very important to have that clarified. Yes?
Is that applied to the aromatase inhibitors like
No.
Arimidex?
No. Arimidex is not metabolized by the same system, so it's not a problem. It's just tamoxifen that is an issue. So here is one depiction of the antidepressant pathway, but there are others. This was the New Jersey Turnpike, I think, shortly after the storm, actually. So I'm going to not focus much now on pharmacology, but on psychotherapy. And this is by way of saying that there is tremendous power in social connection. And this is a review of studies published in the journal Science some years ago. And what showed us a very simple thing, the relationship between social connection and mortality. That people who were low in social integration had higher rates of all-cause mortality and cancer mortality than those who were high in social integration. So loneliness is bad for your health. In fact, it's as bad for your health as smoking or having high serum cholesterol levels. We are really social creatures. And the way this study got started was Leonard Syme, who was a sociologist at Berkeley, which is a small university on the other side of the bay, had some friends over from Japan, and he was showing them around San Francisco. And they weren't enjoying the beauty of the city, and they said, "What a sad place." And he said, "What are you talking about?" They said, "You Americans are so alone. Everybody walks around here by themselves. You never see that in Japan. Girls walk arm in arm in arm, and everybody's talking with somebody. And this is a very isolated culture, which it is, actually. And it gets worse when you get cancer, because people don't want to mention the C word, or even worse, the D word. They don't know what to say. And so many social relations, some get better, but many get worse, and it's harder to start new ones. So social isolation is part of the problem and the stress of dealing with cancer. So what we started doing in the 1970s here was putting together support groups of women with breast cancer. And at the time, we were told that that was a terrible idea, that you would demoralize women by putting them, and these were women with metastatic disease, so they had advanced breast cancer. But we were told that you would make them worse because they would see one another die and you demoralize them. And we were very worried about that. And we actually followed them week by week, word by word, were we demoralizing them or not. After a while, it began to dawn on me that death is not a novel concept to a cancer patient, that watching somebody else die of it is not the first time you thought of it, and that what you deprive them of is the opportunity to see what it felt like, to see how to deal with it. And that's what we did in the groups, and I'll show you some examples of that. There are 7 issues that we dealt with in the groups, and these are themes that I think are helpful for anybody dealing with cancer and other life-threatening illness. Build new bonds of social support. And it is amazing how fast people form intense connections with one another when they're coping with the same illness, because you know what it's like, you've been there. And there are other things too. There's nothing good about getting cancer, but you can use your experience to help other people cope with the same illness. And so something genuinely good comes out of a bad situation. You start to feel like an expert in life. You know something about coping that you can use to help other people, and that makes you feel better about yourself. You can also see the illness from the perspective of your own loved ones, of what it's like to deal with someone who has cancer rather than be the one who has cancer. So you learn a deeper level of understanding for what other people are dealing with and going through. We had one woman, a new woman joined the group who was very ill, lovely woman, very ill, and another member said, you know, I'm going to stop doing this now, but I realize what I've been doing. I've been keeping my distance from you because I'm protecting myself. I can see how sick you are, and I'm sort of protecting myself against loss. And she said, I'm going to not do that, but I now understand how my family have been dealing with me, that they've been protecting themselves in the same way. So you see it from the other point of view. It changes your perspective. We encourage the expression of emotion. Let people talk about anger, fear, and sadness. Emotion can be your friend, not your enemy. It can bring you closer to people if you talk openly about how you feel. You can detoxify fears of dying and death. There's nothing we can do about being dead, but there's a lot we can do about how we die. And many cancer patients are much more worried about the process of dying than death itself. That's a big stressor. We all have to deal with it. But there are even aspects of that that we can take control over. And patients find that they are less overwhelmed by their fears of dying and death when they can face it together. Another way to think of that is that we don't talk about death much in our culture. We don't deal with it very well. But one way in which we comprehend it is being alone. You know, there's an old spiritual that goes, you got to walk that lonesome valley by yourself. Well, what we tend to do is isolate people who are worried about dying, and that makes them feel already a little bit dead. It's very different to talk about death at 2 in the afternoon in a group than to worry about death alone at 2 o'clock in the morning. And patients find that it is reassuring, it is not damaging to them to deal with it. We encourage them to reorder life priorities, like Maurice, who decided to become an artist. If you're not going to live forever, you may want to live differently. And many of my patients say, life has never been the same since I got cancer, but in many ways it's better. So they feel that they can understand and deal better with the illness by changing their own priorities in life and taking it seriously. We try to improve communication with families and friends, help them understand one another and what they need, and deal with things in a more direct and forthright way. Exchanging roles, you know, helping if the patient can't, you know, there was one patient of mine who was very upset. She was in bed, she felt very weak, she'd just gotten a lot of radiotherapy, and her husband was cooking dinner and trying to keep up with things, and she had a kind of meltdown when he said to their child, who wanted help with homework, wait till after dinner and I'll help you with your homework. And she screamed at him, I can't cook dinner, I can't stand over the sink, but I can help our kid with his homework, so send him in here. So, you know, just a sense of being able to do what you can do and exchange roles can be very helpful. Improve communication with doctors. Sometimes patients don't get the opportunity or don't avail themselves of the opportunity to communicate clearly what they want or get their questions answered, and it's very important. And then we do symptom management exercises, and I'll tell you a little bit about that as well. We've written a book called Group Therapy for Cancer Patients that summarizes this intervention program for patients with cancer. So one of our goals in terms of managing distress, stress and distress related to cancer, is to convert anxiety into fear and depression into sadness. Try and find something that is triggering this feeling of discomfort you have in your chest or this overwhelming sense of sadness. And you can then begin to deal with it and begin to think about how to approach it and what to do about it. It's the sense of overwhelming misery that's a problem. And if you keep avoiding the things that make you sad, you are less and less clear about what it is that's troubling you. So use it as a trigger and a signal that it's time to do something, and focus your distress in ways that help you clarify what it is that's troubling you. Shakespeare, of course, said it best. He said, "Give sorrow words, the grief that does not speak, whispers the o'erfraught heart and bids it break." We found in these studies that we actually succeeded in reducing our patients' tendency to suppress their emotions. You know, many cancer patients feel like, you know, crying, it's like opening Pandora's box. You know, if I start, I'll never stop. Well, I've never lost a patient in terminal crying. You know, they start and then they stop, and they usually feel better afterwards. And we found that we could actually reduce their tendency to suppress emotion compared to the control group that were comparable but didn't have the opportunity to come to these groups every week, and that actually improved their mood. So the more open they were about their feelings, the less anxious and depressed they were over time. So it's sort of short-term pain, long-term gain. Dealing with your feelings is helpful, not hurtful. And this was their sense of being competent in dealing with their emotions. And the ones who were in our groups felt that they were handling their emotions better than the control group, even though they were suppressing them less. We dealt with very serious and difficult issues. So when one of our patients died, another one, who was a poet, made these little cards that she handed out. "Dear Eva, whenever the wind is from the sea, salty and strong, you are here, remembering your zest for hilltops and the sturdy surf of your laughter, gentles my grief at your going and tempers the thought of my own." And, you know, there's something healing in that. She was facing it, they were dealing with it, but in a way that led them to feel better about themselves. I don't know if I have, yes, another patient said that what I found in the beginning in the group is like that fear you have standing at the top of a tall building or at the edge of the Grand Canyon. At first you're afraid to look down. I don't like heights, but gradually you learn to do it, and you can see that falling down would be a disaster. Nonetheless, you feel better about yourself because you're able to look at it. I can't say I feel serene, but I can look at it. So just being able to face whatever it is you have to face gives you a sense of handling it better. Avoiding it is damaging. Dealing with it makes you feel better. We encourage people to face the limitations of time and decide how you want to spend the precious resources that you have left. And many of us live with the fantasy that we're going to live on forever and die in our sleep when we're 140. Life isn't like that. And so taking hold of life and taking advantage of whatever opportunities you have is a kind of gift that cancer gives people, because it's not like having a heart attack where you're fine one minute and dead the next. There's warning, and you can give some serious thought to how you want to spend the time that you have. That's both a stress but also an opportunity to live differently and live better. Not everybody gets it, however. He's saying, "I'm sorry, Mr. Rainey, our tests show you have 2 weeks to live," and he says, "Can I take them in August?" I don't think he quite was clear on the concept. Yeah. Oh yes, the Orpheus exercise. So there was an existential psychologist named James Bugenthal who developed an exercise called the Orpheus exercise. And what this involved was we'd had people in the group sit around, close their eyes, and say, make a list of attributes about yourself, things that you are, you know, teacher, lover, skier, whatever it is, and rank order them in importance. And now imagine that you can no longer be the least important one, and ask yourself the question, who am I? So how do you kind of redefine yourself when you have to start giving up things that are really precious to you? And that's what this exercise is. So it's a way of facing in a very concrete and personal way how you redefine who you are when you can't be the things you used to be. As I mentioned, this is my French patient. Patients often feel punished by their doctors and their treatment, and we don't always respond well. He's saying, "I'm sorry, Mr. McConnell, your insurance plan only provides for empathetic nodding and a sad and downward glance. There's a $200 copay for any additional words of compassion, not to exceed 40 words or 3 expressions of sympathy or condolence." And all I can tell you is I wish this were funny. Unfortunately, it's not. You know, something I wished President Obama had said when he was talking about the Medicare system. And, you know, our healthcare system is a catastrophe and has been colonized by predatory insurance companies who want nothing but to make money and who care less about healthcare. And one of the things that President Obama could have pointed out is that the bloated, inefficient, hateful government behemoth healthcare insurance system, Medicare, you know what the rate of overhead for providing care is in Medicare? Anybody know the number? It's 2.7%. Now what that means is that 97.3% of every dollar going through the Medicare system actually goes to pay for medical care. Now, in the lean, efficient, corporate, private insurance system, you know what the overhead rate is? Anybody want to guess? It's 27%. 27. 10 times more than government insurance. And Medicare has to take care of the sickest people because it gets everybody 65 and older. So the insurance industry has spent the infinite amount of money it has sucked out of the healthcare system to make sure that there was no public option. In Obamacare, they would say we can't compete because it's government. They can't compete because government does it so much better than they do. And so it's a real tragedy that we're still having to debate whether we should have any motion towards single-payer healthcare system. In Canada, with a private with a publicly funded fee-for-service system, the overhead rate's 11%, which is still a whole lot better than 27%. So, and you know, one of the other things that just drives me wild is that the leading cause of bankruptcy in the United States is, guess what? Healthcare. In Europe, that never happens. Nobody ever goes bankrupt because of healthcare. So we really have a problem, and we'll know more about what's going to happen to that problem a few hours later on tonight. But it's very sad, actually, that medicine has been colonized by healthcare. And I have to tell you as a physician that one word that makes my skin crawl is the word provider. You know, did you ever hear a mother proudly say, "There he goes, my son, the provider"? You know, I don't think so. It's when European countries colonized Africa and Asia, they came up with demeaning terms for the natives to justify the occupation. And that's exactly what the insurance industry has done with medicine. That, you know, I'm not a provider, I'm a physician. There are nurses, psychologists, social workers, other professionals who care for patients. And to call us providers is a way of saying one of you is as good as another, and we're the ones who are running the show. And it's a very bad thing for healthcare, and I'm sure you've all dealt with this in dealing with your healthcare decisions. It isn't government that's interfering with your healthcare choices, it's private insurance. They tell you who you can see and who you can't because they tell you what you pay for and what you don't. So we've got a real problem here because we want to offer these kinds of things to people, and we have private insurers who are making it very difficult or impossible to do it. It's a real tragedy. So what can patients do to deal with physicians in a more constructive way? And what can physicians do to help patients deal better if they've got the time to do it? Communication, control, and caring. Communicate clearly with docs. So another way to handle the stress of being ill is to communicate your situation clearly. We're physicians, we're not mind readers. We don't always know what it is that is troubling you the most. And I advise patients, if you've got your, you know, your typical list of questions that you always have, here's the trick. Give it to the doctor at the beginning, not the end of the interview. You know, usually you let the doctor do his or her thing and then you do it, by which time he or she has 15 people out there waiting and they've already allotted the amount of time they have. So you just say, whatever amount of time you have with me, I hope some of it will be devoted to dealing with these questions. It works a whole lot better. So you have a right to get your questions answered, but do it in a way that's respectful of the doctor's time and need to care for other patients as well. Control. Patients feel better about the care they're getting if they feel in control of those aspects of it they can control. So participate in decisions. Where there are choices to be made, you have a right, it's your body, you have a right to be involved in those decisions. There are some decisions that just have to be made medically. The patients can't make them. But there are a lot where there really are trade-offs, and it's a good idea to participate in those decisions. Studies have shown, like in where there's a trade-off between lumpectomy and mastectomy, for example, that patients who felt that they participated in the choice were happier afterwards regardless of which choice they made. So participating really makes a difference. And finally, the sense of caring. You know, in medicine, the oldest adage in medicine is that our job is to cure rarely, relieve suffering often, and comfort always. And when medicine got scientific and interventional, we changed our job description to be that our job is to cure always, relieve suffering if you have the time, and let someone else do the comforting. And that's a bad mistake. We painted ourselves into a corner, because no matter how good medicine gets, the death rate will always be 1 per person. You know, sooner or later, we're all going to die of something. We're going to need well-trained professionals to help us do it. And so the idea that we're there to cure all the time is just wrong. That's not what we do. When we can, by all means, go for it. We do it. But there's a lot of other things that are involved in healthcare that we tend to overlook. So do these groups help people? He's saying, do you remember what you were feeling before you ate the other members of the group? It's a rare side effect of treatment, doesn't it? Yes, these groups help people. So we had these women with advanced breast cancer, 90 minutes once a week, sit there and talk about these themes that we've mentioned. And what you see is that the women in the support groups got less anxious and depressed over the year. The women in the control condition who didn't get the support groups got more anxious and depressed. So talking about these problems relieves them. It doesn't make them worse. And we were able to repeat this finding in a new study 15 years later, showing greater reduction in distress in the treatment group than the control group. So we have solid evidence, and other groups around the world have evidence too, that helping people face these problems reduces their distress. It doesn't add to it. This is, I don't know, have any of you heard of Cochrane database reviews? Anybody? There's a Cochrane collaborative. It was funded by a very wealthy businessman named Cochrane, who felt that a lot of medical practice was not based on the best review of evidence. So he paid for people to go through and review evidence about all kinds of treatments. And in fact, when Cochrane himself had a heart attack, he decided to forego one of the common treatments at the time because his own database review said doesn't help. You know, and he's still alive, so I guess he was right. This is a review of the effects of group psychotherapy in treating depression among cancer patients, even advanced cancer patients. And what it shows is that the treatments are effective, that they help people. So the summary is, from a very dispassionate and tough-minded review, that these things actually help, they don't hurt patients. So that was our concern early on. If I'm convinced of anything from 35 years of doing this, it's that it helps people to bring them together to deal with these kinds of stressors, including the worst kinds of stressors. Now, one of the other things we do is we teach patients techniques like self-hypnosis to control symptoms like anxiety and depression. My daughter Julia did this drawing. My dad hypnotizes people and makes them want to live longer, and you see a particularly successful clinical example here. Now, Julia is now a senior law student, but she says to me, "Dad, are you still showing that drawing of mine?" So I do have to tell you that it doesn't represent her current level of artistic or intellectual ability. But hypnosis is just a form of highly focused attention. Like, how many of you have had the experience of getting so caught up in a good movie that you forget you're watching the movie and you enter the imagined world? Any of you never had an experience like that? For some, it depends on the movie, I guess. But hypnosis is just a form of focused attention. It's like looking through the telephoto lens of a camera. What you see with great detail, but you're less aware of the surroundings. Now, we all do this naturally. So these, you know, you probably are having sensations by now in your bottoms touching these wonderful soft chairs that Stanford has provided you. Hopefully that was not foremost in your mind until I brought it to your attention. So our brains are very good at paying attention to some things and putting outside of awareness others. Hypnosis is a more disciplined way of doing that, and you can actually reduce or even eliminate pain in doing it. And I had the opportunity a couple of weeks ago in New York to give a presentation to His Holiness the Dalai Lama. We were interested in mindfulness, compassion, and health, and how they were related. So he said to me, I was talking about hypnosis, he said, well, Doc, it doesn't actually change the pain, does it? It just changes how you react to it. And I said, no, we actually have brain imaging studies that show you literally reduce how much pain people feel. And he said, well, can you help me with my right knee? He said, it kind of hurts. So I said I'd be honored to do it. He said, well, I'm too skeptical. I wouldn't be a good subject. And I told him, we have ways of dealing with that, so I may have an opportunity to do it. But what this shows is that while pain signals travel up to the brain through the part of the spinal cord called the spinal thalamic tract and are processed in the brain, there is top-down modulation of pain too. So the meaning of pain, how surprising it is, whether you think it means something is getting worse, are all factors that can literally change how much pain you feel, as you see here. I think you can see the baby's getting the shot here, and the father is the one who's in pain. So the meaning of the pain has a lot to do with it, and we can use that to help people, even with very serious pain, do better. This is an EEG time locked to presenting a series of shocks to some Stanford students who volunteered in a study. And the red line is the brain's normal electrical reaction to these shocks here. The yellow line is the brain's response to the same shocks, but delivered while they were hypnotized and told, your hand is in ice water, it's cool and numb. And you see that these early components just about disappeared, and the later ones were only half as big. So we literally changed the way their brains responded as rapidly as as rapidly as a tenth of a second after the shocks were administered. So you can literally transform what pain you feel. And these are studies done by a researcher named Pierre Rainville in Montreal, showing parts of the brain that are involved in analgesia using hypnosis. And the main point here is that the words you use change the part of the brain that is involved. So if you say to people, your hand is cool and numb, the way we did in this other experiment, it's the somatosensory cortex, the part of the brain that processes sensation here, that turns itself down. If instead you say, well, the pain's there, but it won't bother you, which many people feel when they take opiates. It's there, but who cares? It's a different part of the brain called the anterior cingulate cortex. And this part is a kind of worry center in the brain. It tells us what to worry about, what to pay attention to, and what not. And that part of the brain is also involved in hypnotic analgesia. So we know specific parts of the brain. So this is not a matter of fixing your brain, it's a matter of using your brain to actually alter the way you perceive pain. And we teach patients to do that as a self-hypnosis exercise. So they don't need me with them at 2 in the morning. They need to know how to do self-hypnosis to alter, transform their pain experience. And this is what we get at the end of a year of teaching patients self-hypnosis. The women in our support groups had half the pain the control group did on the same and very low amounts of medication. So it's highly effective in helping people to control even chronic and severe cancer pain. And this is a replication of that study, again in a new sample 15 years later. So we can help people live more comfortably and reduce their pain. So the next question is, well, what effect does this better coping, this better stress management, this better pain management have on the course of disease? And I initially thought not much. I thought it was an interesting idea. There was a guy, any of you know Carl Simonton, have you heard of this? He wrote a book called Getting Well Again, and the idea is you just visualize your white cells killing your cancer cells, and lo and behold, it will happen. And I thought it was an interesting idea, but there was no evidence that it was true, and there still isn't. But I decided to follow up on these early studies we did, because we knew we'd help these women emotionally and see what happened to them physically. And much to my surprise, we found an effect on survival. So the women who were randomly assigned, random assignment simply means you can't choose whether you're in the treatment or the control group. The computer chooses for you. Because if you let people choose, the problem is if you see a difference, you don't know if the difference is due to the fact that certain kinds of people will choose one thing versus another. So this is a fundamental basis of clinical trials, is that you randomly assign people to different treatments. Whoops. And what you see here is that by the end of 48 months, 4 years, all the controls had died, but a third of the treatment group was still alive. And this wasn't due to any differences in the medical treatment they got. The average difference in survival was 18 months. So we published this in The Lancet in 1989, and we got a fair amount of attention for this. And I was surprised by it. You know, I was pleased, but I didn't expect that we would see what amounts to a pretty hefty effect on survival. So a number of people tried to replicate this study. We did. And when we did another study that we published about a decade ago, less than that, half a decade ago, we found that we didn't get an overall survival effect, but we got an interaction with whether the patients were ER negative or ER positive. So estrogen receptor positive breast cancer is better in some ways because it responds to hormonal treatments, which we didn't have 30 years ago, but the ER negative tumors do not. And what we found was that the ER positive patients didn't get a survival advantage, but they were doing better anyway because the hormonal treatments were better. The ER negative patients had the same kind of difference in survival that we had seen in the earlier study. So the ones who weren't benefiting from newer treatments did survive longer if they were in our support groups compared to controls. And in fact, overall survival, mortality from breast cancer has been going down in the period between our first and our second study, largely because of better hormonal and chemotherapy treatments. So the treatments have improved. That's great, and I'm always pleased whatever it is that works, but we think that may account for some of the differences. This is a study published by Barbara Anderson at The Ohio State University. She did a similar kind of group therapy, but more educational in nature, for women with primary breast cancer, so earlier stage disease, and she found, an effect on survival as well. So the ones who got the psychotherapy lived significantly longer than the ones who were in the control condition. There's another study that was published just a year ago in the New England Journal of Medicine for people with end-stage lung cancer, non-small cell lung cancer, very serious disease. They were treated with palliative care, so treating their pain, their depression right at the end of life. And they were able to significantly reduce their depression, to some extent their anxiety as well, and they lived 2.5 months longer, significantly longer, if they got the palliative care compared to standard care. So there are now 8 studies, 8 randomized trials that show that emotional support for cancer patients not only improves quality of life, it actually improves quantity of life. However, there are 7 other studies that show no difference. I'm glad to say there are no studies that show that psychotherapy kills patients. That doesn't happen. So the studies are not randomly distributed. The studies, if anything, show that psychotherapy helps, but not all of them do. So others are still doing this research. I'm still doing this research. I think it's still an open question. But by now, I think it's a pretty interesting question about whether handling the stress better, facing it directly, altering your perception of your situation and your perception of pain, coping actively, expressing emotion, getting social support, doesn't help you not just improve the quality of life, but improve the quantity of life as well. Another picture of from my French patient showing how punished she felt and sort of wistfully seeing an image of herself before her treatment. So you had asked a question earlier on, so what are the mechanisms? Well, that's a complex area. We're still working on it, but before I stop and take questions, I'll give you some ideas that we have and some data that we have.
Describe to us how the different parts of the brain can be accessed depending on what words you use.
That's right. And so the follow-on from that is that different parts of the body can be accessed too. So one system that we're very interested in is the hypothalamic pituitary adrenal axis. This basically, it's a long word for a stress hormone called cortisol. Cortisol, it mobilizes glucose in the blood. It prepares you to fight or flee. It's secreted by adrenal glands here on top of the kidneys. And there's a complex system that allows the brain to trigger a hormone called CRH that goes to the pituitary, that secretes ACTH that goes around in the blood and tells the adrenals, okay, pump out cortisol, you need to raise your blood sugar. But it wouldn't be good for if you did that all the time. So the system has this very delicate feedback regulation so that once the stress is over, you turn the system off and you go back to normal. However, and that doesn't always work, particularly with depression. So this is a nice normal daily pattern of cortisol. Our cortisol levels are highest in the morning. And by now, your cortisol levels should all be quite low. We're down here, except with the election, they may start to go up again very quickly, depending on the results. People with depression tend to not have this nice daily variation of cortisol. It tends to be high and flat. PTSD low and flat. So the daily variation is part of a normal body response to the stress of waking up in the morning, among other things. We found among our breast cancer patients that a lot of them had abnormal cortisol patterns. They didn't have this nice high level in the morning going down late in the day. They had either flat or even increasing patterns throughout the day. Mm-hmm.
Go back one slide for a moment.
Yeah.
This is the very bottom.
Yeah.
Want to just speak to the fibromyalgia?
Yeah.
Piece? Chronic pain, fibromyalgia, in terms of, real specific patterns, pretty flat, little dips up.
Yes. Oh, here. Yeah, here's what you're saying. Yeah. Well, it seems that people with fibromyalgia have a number of hormonal and also immune function problems, and that people with fibromyalgia tend not to have this nice normal daily variation in cortisol, and it may be something that contributes to the fibromyalgia. It's a complicated thing. There's a mood disorder associated with it as well, but yes, there is evidence that people with chronic pain or fibromyalgia have this abnormal cord pattern, and what we think happens is that they kind of burn out the system. I don't think I have the slide here, but basically this cord system can be something like an overused light switch, that if you keep turning it on all the time, sometimes it just stays on, so you lose that ability to shut the system down when you need to, or at other times it stays off, which is more like what you see in this fibromyalgia and PTSD pattern. So the system does not correct itself, and you either don't have cortisol when you need it, or you have it around all the time when you don't need it. That's been called allostatic load. It's how chronic stressors can degrade the body's response system to stress. And we found that that isn't a good thing for breast cancer patients. So the ones that had these abnormal patterns where they tend to stay high actually also had shorter survival than the ones who had the normal cortisol patterns. And again, this is a prediction independent of all the other risk factors. So it suggests that having a normal stress response system is an important factor, and this has recently been seen with lung cancer patients as well. Sandy Sefton, who did the original work on the diurnal cortisol pattern in breast cancer, found the same thing with lung cancer patients as well. So it seems that an abnormal stress response system may increase risk for shorter survival with cancer. One of the factors that's associated with it is poor sleep. So the ones who have these abnormal patterns don't sleep as well. They wake up more during the night. And sleep disruption, I mentioned the grandmother effect earlier, can be a real risk factor as well. So we're looking now, we're actively studying. We've had a number of wonderful people with cancer come in and help us study their sleep wakefulness patterns and their hormonal patterns, and we're actively investigating that now. And some of our early work suggests that people who are having the most trouble sleeping do not live as long. And this is not like 2 weeks before you die. This is years before. So a good stable pattern of sleep actually is a good predictor of better survival.
Dr. Stanley?
Yeah.
How would, especially women who are going through menopause and have trouble sleeping as they're going through menopause, how would that affect this cortisol?
Well, that can certainly, it can contribute to the aberrant patterns. That if you're waking at night, you're probably triggering an acute cortisol response. The more frustrated you are, the more you're doing it. Menopause, of course, has its own hormonal factors, and women getting breast cancer treatment, if they haven't been menopausal, become menopausal due to the treatment. So that can complicate the situation, and what we want to do is help them reestablish normal sleep-wake patterns as best we can. And there are good therapeutic treatments, some medications, but they tend to be overutilized, and other kinds of sleep hygiene and sleep training treatments can be very helpful. And I'll give you one tip. It's a more complex thing. But if you can see your clock from your bed, turn it around. Because seeing what time it is when you wake up in the middle of the night is an arousal cue, and what you're doing is waking yourself up more. So it doesn't matter what time it is. You set the alarm if you need to, but you don't want to know in the middle of the night what time it is when you're waking up. So things like that can help you actually sleep better, even if you're having difficulty sleeping. One of the other reasons that Oksana Polish in our group found is that people who sleep better at night have better abilities to control their nervous system arousal during the day. We call it vagal tone. It's the ability of the parasympathetic nervous system to slow heart rate and lower blood pressure. And we all know this. If you've not had a good night's sleep, and even minor things happen the next day, you're not at your best. You're angry and fussy, and you just don't handle those stresses as well as you do if you've had a good night's sleep. And so we have better vagal tone among our cancer patients who sleep better at night. So it's another reason to eat well, sleep well, and get plenty of exercise. And exercise during the day will help you sleep better at night. And this was an article back when there was a Time magazine of talking about sleep and the fact that losing sleep, cancer might be something to lose sleep over, but we'd rather regain the sleep and lose the cancer. And there's some evidence that sleeping better may help you with that as well. So some of the factors that we think can translate from stress management into differential rates of tumor progression include these circadian rhythms of sleep and wakefulness, these stress hormones, and effects on the immune system as well. And that's another complex but interesting area where we think these stress hormones can inhibit functions of the immune system that have to do with cancer surveillance as well. Women with these abnormal cortisol patterns had lower numbers of natural killer cells. And these are cells natural cells in the immune system that actually kill transformed and dying cells. They don't recognize external antigens like viruses and bacteria. They recognize transformed cells in the body, and they are involved in tumor surveillance. So the women who had these abnormal cortisol patterns actually had fewer natural killer cells in their blood. So that's another possible connection. We found that high depression was associated with poor natural immunity. So, when you've got a TB test, you have an antigen stuck under your skin, and 48 hours later you see if you have an immune response to it. So it's a low-tech but natural way of measuring the body's immune system. And those of our patients who had higher depression scores had poor natural immunity. So depression and high cortisol levels can actually interfere with the body's natural immune system. This is work from a group at Texas, MD Anderson Medical Center and University of Iowa, showing that another stress hormone, epinephrine, which increases heart rate and is secreted by the adrenal medulla, is actually associated with more rapid tumor growth in animals. And I think you may be able to see here that there's more growth here than here. And the epinephrine, among other things, stimulates blood supply to support the tumor. There's a substance called vascular endothelial growth factor that is higher in these animals when they're stressed. So there are a number of hormone systems that seem to have an effect on tumor growth. And this is just a sort of a little diagram here that they provide showing how the stress and the norepinephrine production can trigger vascular support and allow tumors to take hold more. So there's reason to think, we should handle stress better just because your life will feel better if you do. But it's also possible that it may help your bodies cope better with the illness as well. And in fact, there's a clinical outcome of this now. There's a drug called propranolol, or Inderol. You may have heard of it. It's a beta blocker. It blocks sympathetic arousal. And somebody got the idea, I wonder if breast cancer patients who happen to get Inderol because they're hypertensive have a different outcome with their breast cancer. If this was right, that it may have an effect on tumor blood supply and growth. And sure enough, the answer was yes, that the ones who happen to be on Inderol actually live longer than those who are not. So it suggests a whole new way of treating cancer that may have more to do with stress management and even medications that help with stress management than controls. And this is just another study showing the same thing. Even with triple negative, that is ER/PR negative breast cancers do better if they get Inderol. So it's a whole new way of thinking that stress management may help us better manage overall people with cancer. A couple of other mechanisms. One of them involves telomeres, and you may have heard about telomeres, which are the capsid ends of chromosomes. They get shorter as we age, so mine are still pretty long, but yours, I'm sure, are very Elizabeth Blackburn, who's a faculty member at UCSF, won the Nobel Prize for this a couple of years ago. She's a delightful person. And she's also shown that stress is associated with shorter telomeres. So caregivers who have high stress actually have shorter telomeres and less telomerase, less active telomerase, which helps to repair the length of telomeres. So we're now studying this in collaboration with her to see what the effect of cancer-related stress is to telomere length. there is evidence that cortisol actually inhibits the activity, the expression of genes that are tumor suppressor genes, like BRCA1. You've heard of that. If there's a mutation in that gene, the rate of breast cancer goes from like 7 or 8% to 85%. Cortisol applied to this gene can inhibit its activity. And there's another gene like that called P53, which is a major tumor suppressor gene. What these genes do is they basically, when cells start to transform and don't function right, they send it a drop-dead signal. So the cell dies rather than continuing to proliferate. But stress can inhibit the activity of that gene as well. So we're learning more and more that stressors in various ways, through hormones, through immune function, and through effects on gene expression, may actually affect how well people live and how long they may live with cancer. And this is just another example of the data showing that stress and cortisol inhibit P53 gene expression. So, in summary, we think that stress and the way people handle it, their emotional and social support, their cognitive adaptation to the illness, can affect hormones that involve stress, can affect immune function, can affect the expression of genes that have an effect on the body's ability to fight cancer. Our goal is to transform people from feeling damaged by the disease to transcending it. When you see the Winged Victory of Samothrace at the Louvre, it's a stunning piece of art. You don't say, oh my, there's a woman who's missing her arms and her head. You see it as an image of transcendence. So our bodies can be damaged and we can still transcend, and that's what we try to teach people in dealing with the stresses of cancer. So again, we think cancer is best handled by facing rather than fleeing, altering your perception of the situation, coping actively, expressing emotion, and seeking social support. In that sense, feeling may lead to healing. So my French cancer patient said, you know, you have some calm days, you have some better days. Oh my goodness. Okay, we'll turn that off. You have some calm days. And she did the typical French thing. She made a meal of the crab. She barbecued it. And she says, alors courage. So in summary, psychotherapy works. Depression and psychotherapy may affect disease progression as well as quality of life. Feeling better may lead to healing better. It isn't just mind over matter, but mind matters. This is some of the wonderful people in our Center on Stress and Health who have helped us study this. And again, I'm grateful to our patients as well who have given a great deal of their time and energy. I also want to thank our support. And one of the great things our federal government does is the National Institutes of Health, which provides world-leading support for all kinds of research that help us improve the quality and quantity of life. The National Cancer Institute, the National Institute of Mental Health, the California Breast Cancer Research Program, a wonderful program, the Dana Foundation, the MacArthur Foundation, and others. And without their help, we couldn't be doing what I have been presenting to you here. Shakespeare said, when we are better see bearing our woes, we scarcely think our miseries our foes. The mind much sufferance doth o'erskip when grief hath mates and bearing fellowship. But the mind-body relationship is nothing to fool around with. He's saying, what happened to your sergeant? He said it's a placebo overdose. We're pretty sure he only thinks he's dead. So thank you for your attention.
For more, please visit us at stanford.edu.